Okay. Our next speaker is Dr. Rayne Rouce, who will be presenting Are We There Yet? A Cancer Cure Maybe Just a Car Ride Away. Dr. Rouse is a pediatric oncologist and physician scientist who has dedicated her career to identifying innovative ways to harness the immune system to attack tumors. Her clinical practice at Texas Children's Cancer Center largely consists of children with high-risk hematologic malignancies with limited curative options. She works in the Center for Cell and Gene Therapy, a research laboratory dedicated to translating investigator-initiated immunotherapy from bench to bedside. Dr. Rouse has extensive experience in the clinical use of CAR T cells and is focused on ensuring that this therapy benefits as many children as possible as safely as possible. Please welcome Dr. Rayne Rouce.
Thank you. Good morning, everyone. I'm really excited to be here today. My goal today is to address just how close we are to curing cancer using CAR T cells, but also how far away. Here are my disclosures. So at the conclusion of the session, participants should be able to state the rationale and indications for using CAR T cells to kill cancer, summarize the current results and risks associated with CAR T cell therapy, and perhaps most importantly, outline the key aspects of CAR T cell therapy that are pertinent to general and subspecialist pediatricians alike. So I'd like to start with the clinical scenario. It's Friday afternoon, it's 4 p.m., you have one patient left to go, you're hoping it's a simple one, and you note the chief complaint, 4-year-old male with 1-week history of bruising and rash. You obtain a CBC, the results come back later that afternoon, and you find yourself smack dab in the midst of every pediatrician's worst nightmare. So you try not to jump to conclusions and you go through the possible differential diagnoses for pancytopenia in your head and you say, well, this kid did have a cold a couple weeks ago, maybe this is just viral suppression, or perhaps this is an atypical case of iron deficiency anemia, or maybe even ITP. But the following morning, the differential is released and the peripheral smear reveals your suspicions: acute lymphoblastic leukemia, the most common childhood cancer. Odds are, if this exact scenario has not happened to you yet, it will. So what next? You've been in this situation before. You've become a pro at navigating and helping parents navigate the next steps in the workup to a diagnosis of cancer. You are used to the chemo cycles. You may even remember some of the names. You may not remember the exact length, but you know that therapy will likely include a combination of chemotherapy and perhaps even radiation. Even for the most common childhood cancer, pre-B acute lymphoblastic leukemia, the road to a cancer cure is riddled with roadblocks, some big, some bigger. When we take traditional routes, the diagnostic workup for some cancers can even take up to 1 to 2 weeks. So this is a huge thing for parents and patients to surmount. Most therapy includes a combination of chemotherapy, often radiation. For some solid tumors, we do surgeries. And lastly, for higher risk tumors and patients who have residual disease early on, more recent protocols have actually incorporated investigational therapy early on. So using traditional routes, this road to a cancer cure is about 3 years. All of you guys are very familiar with the short and long-term effects of cancer therapy. Whether you're a pediatric hospitalist or ER physician managing a patient with febrile neutropenia, whether you're a nephrologist who's been consulted to manage acute kidney injury secondary to high-dose methotrexate, or even if you're an endocrinologist helping manage hyperglycemia secondary to steroids. But we're now in the era of personalized targeted therapy, and cancer care is no different. In 2019, the diagnostic workup as well as the treatment routes are very different. They're more personalized, they're more sophisticated. So the journey, the alternate routes, and not only the roadblocks are very new and very unique. So how will you respond when your patient's savvy parents ask you about CAR T cells? You've heard of CAR T cells, maybe you've seen a special on HBO, maybe you've read an article about them, but are you prepared to answer the barrage of very sophisticated questions that your patient's family are asking you about? Well, fortunately, you've come to the right place. Welcome to CAR T Cell 101. Don't worry, your registration is covered by your NCE fees. So what exactly is a CAR T cell? CAR stands for chimeric antigen receptor, and these are T cells that are engineered to express artificial receptors that specifically target an antigen or a protein on the surface of a cancer cell. How do we make these? In the laboratory, we use an inactivated retrovirus, which is kind of a cousin of the HIV virus, and we use this to carry a gene encoding the genetic machinery that creates these artificial receptors into the T cell. We expand these cells in the laboratory, and then we have all of these superpower T cells that express these specialized receptors. So when we put these CAR T cells into the body, they actually are trained killers, go right to their antigen, attack them, and are able to kill the cancer cell. What's involved in making them? This sounds pretty complicated. The whole manufacture process only takes about 3 to 6 weeks, believe it or not. So we start with our relapsed or refractory cancer patient. They undergo leukapheresis, which involves placing typically a pheresis catheter, getting on a machine that's very similar to a dialysis machine, and filtering out only the white blood cells, then taking them to the laboratory, and then specifically filtering out only the T cells. We next use our inactive virus to genetically modify the T cells and basically train them. We put them through a training program in the laboratory so that at the end of the process, we can expand these cells and we have all these super fighter T cells that their eyes are only on the antigen that we want them to be on. We can actually freeze these cells until they're ready for infusion into the patient. So CAR T cells have been around for a while, but you've probably only started to hear about them over the most recent years. They've been around for over 15 years, however. And the first CAR T cells that we used in the clinic about 10 years ago are called first generation CAR T cells. And these were made up of two very simple parts. Okay, I'm not going to lose you guys here. Don't worry about these fancy pictures. So the first important part is the antigen recognition domain. And this is derived from a monoclonal antibody. So if you have a monoclonal antibody, you can take that sequence and you can create this special receptor that recognizes the antigen. The second part is made up of the T cell killing capacity, the zeta chain of the cytotoxic T cell. So we join those together in the laboratory. And when we put these cells into patients, we were really excited. They got really activated. They recognized the antigen on the tumor cell the way they were supposed to. But unfortunately, they got pretty lazy. They got exhausted. So they did a little bit of killing and then they went and chilled out for a minute and we couldn't get them to wake back up. And what we actually realized is that they needed a little bit of additional internal stimulation. So before, the first generation CAR T cells are like the floor model. The second generation CAR T cells are the souped up V8 engine with the rims. So our second generation CAR T cells actually had a built-in battery pack of sorts. So we built in internal stimulation switches that when the CAR T cell came into contact with this antigen and got super excited and started killing it, it didn't putter out. These CAR T cells are actually very successful and the ones that are currently used in clinic. And not only did this built-in activation switch allow the CAR T cells to kill better, it allowed them to grow massively in number and triple, quadruple, billions and billions of cells within the body. The next thing we learned is that we couldn't just go all willy-nilly and place these CAR T cells into the body and expect that they would play nicely with the other immune system cells in the body. So we realized that we had to actually make space for them. So what we do is we give a few days of what we call lymphodepleting chemotherapy to make room. So it actually clears out some of the lazy T cells that have been in residence in the body and makes room for these cells to grow and expand. So we'll next talk about what I like to think of as the holy grail of CAR T cells, the CD19 CAR. Who's heard of a CD19 CAR T cell? Raise your hand. Few people. So CD19 has been so successful, but why? Well, CD19 is actually an ideal target. The upside is it's present on the vast majority of pediatric B-cell ALL, and it's also present on the majority of B-cell lymphomas. The downside, though, is that CD19 is present on normal B cells. So while these CARs are smart, they're not quite that smart. So they're unable to distinguish between a good CD19 on a normal B cell and a bad CD19 on a malignant leukemia cell. So patients who do receive this therapy do typically require long-term IV immunoglobulin replacement because the CAR T cells continue to kill their normal B cells over time. So I don't think any oncologist could ever have imagined, and this is the research I've done for years, that the CD19 CAR T cell would be quite as successful as it has. and it just really works. Up to 90% of patients with heavily pretreated relapsed refractory leukemia lymphoma who failed even bone marrow transplant will achieve complete remission following a single dose of these CAR T cells. This is significant. Every time I treat a patient with CAR T cells, I think about patients who I had when I was in my first year of fellowship or my second year of fellowship prior to the invention of CAR T cells and prior to the success. And I think about how they would have benefited from this therapy. We've also gotten pretty smart. We're able to actually track these CAR T cells in the body because they're gene marked. So we can follow persistence. And we now know that persistence in the blood and in the bone marrow is directly related to ongoing remission. And some patients remain in remission for years. The focus the last few years has been expanding access. We've had larger trials, longer follow-up, high remission rates, and this has led to partnerships with industry with the sole goal to make this therapy more widely available and actually prescribable. So prior to 2017, CD19 CAR T cells were actually only available at around 8 to 10 centers in the country. So imagine a family and a patient with relapsed refractory cancer having to fly and uproot their family across the country to receive this therapy. But in August 2017, we had the first FDA approval of a CAR T cell therapy. So now this therapy is currently available at around 30 centers in the country. So the chances are, if you haven't yet, in 2019, you are likely to take care of a patient who's received CD19 CAR T cells. Yeah, that deserves a little bit of applause. So let's pause for a moment and take a look at the real world impact of CD19 CAR T cells. This is a historical survival curve of patients with pre-B ALL who have relapsed and entered remission after 2, 3, 4, 5, 6 rounds of salvage therapy. And as you can see, the highest event-free survival at 2 years is around 40%. However, 80% of patients who receive CAR T cells remain in remission at 1 year. At 6 months. And at 1 year, 60% of those patients are still in remission. So imagine if that patient who remains in remission at 1 year is still in remission at 2 years or 3 years or 4 years. Could we effectively be doubling or perhaps even tripling our long-term survival for these patients who failed all other therapies? It's really exciting to think about. So like most good things, there is a dark side of CAR T cell therapy, and it's one that's been very heavily covered in the media for good reason. So what exactly happens when we inject these highly motivated killer T cells into the body? We usually put them in through either a peripheral IV or a central line. And remember, they're trained to recognize antigens, so they track directly to the tumor site. Once at the tumor site, these CAR T cells do exactly what we've trained them to do. They get in there, they attach to the cancer cells, and they create massive tumor lysis. But in doing this, they also create a very inflammatory environment that releases lots of inflammatory cytokines into the circulatory system. This creates a syndrome known as cytokine release syndrome, or CRS. Cytokine release syndrome actually occurs in the vast majority of patients who receive CD19 CAR T cells, and it's much more pronounced in patients who have higher disease burden. These patients can have fever, often up to 104, 105, 106, very refractory to antipyretics. They can have hypotension that's fluid refractory. They typically require pressors and transfer to the ICU. And they can also have significant respiratory distress because they have a lot of capillary leak. And so these patients often will require positive pressure, including mechanical ventilation. Fortunately, a few years back, we identified the key cytokine that is the cause of all of these symptoms, which is IL-6. So we actually have a very readily available antidote that's now FDA approved for treatment of CAR T cells. So this is a very manageable syndrome. There are a number of other toxicities, and fortunately, they occur less frequently. Up to 30% of patients can have neurotoxicity, and this is actually very striking, and we're still doing a lot of research on it because it's a little bit less defined. But these patients can have aphasia, they can have stroke-like symptoms, they can even have seizures. This typically is transient and does respond to corticosteroid therapy, thankfully. These patients can have cardiac, pulmonary insufficiency. They can have hepatotoxicity and acute kidney injury, often requiring dialysis. Fortunately, the majority of these symptoms do resolve within the acute post-infusion period when patients are having cytokine release syndrome. So we can actually take a step back and break the toxicity down into 3 separate areas. So we have the immediate. It's actually very rare to have an anaphylaxis or allergic reaction to CAR T cells, which is a good thing. And then we have the things that happen in the short term, including cytokine release, neurotoxicity, cytopenias, and risk for infection. This is namely related to the preceding lymphodepleting chemotherapy, but there also appears to be some component of the very inflammatory environment these CAR T cells cause, and also organ dysfunction. And lastly, because these CD19 CAR T cells will target anything that expresses CD19, we also see B cell aplasia, and typically these patients do require IVIG replacement. So what about the long-term care of the pediatric patient who's received CAR T cells? What does the pediatrician need to know? So 1, are these patients exactly like bone marrow transplant patients? Meaning, can they go to school? Can they be vaccinated? Should steroids be avoided forever? We're very aware of the detrimental effect of steroids on T cells, and we try to avoid them unless there's a life-threatening incident in the immediate post-infusion period. But do you have to worry about it long-term as their general pediatrician? What about long-term effects? What about these organ-specific effects or immune system, cognitive? The truth is, do we really know? The longest survivor of CD19 CAR T cells, Emma Whitehead, was treated at 7 years old and is now 14 years old. And she has become the face of CAR T cell therapy. And most importantly, she is now 7 years cancer-free after a single infusion of CAR T cells. So fortunately, we have been able to answer some of these questions. So patients typically can return to school a bit earlier than with traditional chemotherapy. So normally when their blood counts recover, which is usually about 2 to 3 months after the infusion of CAR T cells, and they can be vaccinated, but we do recommend using the same exact strategy as we use for bone marrow transplant patients. And fortunately, steroids are actually not as detrimental to the CAR T cells as we thought. So you don't have to worry when you have that 9-year-old with an asthma exacerbation who comes into the ER. You can go ahead and give them a burst of steroids even if they are 9 months out from their CAR T cell therapy. So this is really important stuff to remember. The organ-specific long-term effects typically do resolve within the immediate post-infusion period. And again, most patients will require long-term immunoglobulin replacement. We recommend at least for the first year, and after that, you can check IgG levels and use their clinical course to help you out. And very fortunately, we have not seen any evidence for long-term cognitive effects. So this is the really exciting part of the presentation where I get to share with you a story. So I'd like to share with you Jace's CAR T cell story. So Jace was diagnosed with pre-B ALL right before his first birthday. I took care of him. I was in the hospital. I was attending on service. And he had a very refractory pre-B ALL. So much so, it did not respond to chemotherapy, and actually he underwent bone marrow transplant a few months after diagnosis, only to relapse 3 months after bone marrow transplant. So this is Jace here on the right side, like a champ, like the superhero that he is, with the pheresis catheter in his neck, getting his T cells collected to manufacture CAR T cells. And then here's Jace literally 30 seconds after I infused his CAR T cells because the playroom was open and he had business to take care of. So he was on the go. And then I'm happy to report that Jace is now about 2 years out from his CAR T cells and remains in remission. I'm from Texas, where JJ Watt is a huge superhero, but to me, Jace is also a superhero. There are too many faces of CAR T cell success to count, but the one thing that they have in common, aside from their really bright smiles, is their really bright futures. So we talked about the good, but what about the bad? Up to 40% of patients who receive CAR T cells will actually relapse after, and leukemia proves again, as we get smarter, so does it. So leukemia can actually shed the CD19 from its service, so it's indistinguishable to our CAR T cells, but fortunately we have newer protocols where we can target multiple antigens, including CD22. We can't prevent a CD19 positive relapse, but we can detect it earlier using surveillance marrows, and we actually have evidence now that detection of B cell recovery early on can signal an impending relapse. So the current state of the land is these therapies are still only available for patients with relapse refractory disease, and they're quite costly, but most insurance companies do pay for them. But we do have newer investigational trials that are looking at replacing rounds of cytotoxic chemo with the therapy. And I've talked a lot about CD19, but I briefly want to touch on other cancers. There are challenges outside of CD19. For one, the antigens are either not as widely expressed on the tumor or they're expressed too widely. So you don't want to make a CAR T cell against an antigen that's also on heart tissue or lung tissue, obviously. And the tumor microenvironment is actually pretty hostile. It's challenging, but not impossible. We're pediatricians, right? So nothing's impossible. So at our center, I want to share with you a couple of trials. We've been able to engineer a CD5 targeting T cell that targets CD5 on refractory T cell leukemia and lymphoma, which is notoriously difficult to treat. You don't have to be a radiologist to see this massive bulky disease in this patient pre-CAR T cells. After a single dose of CAR T cells, this patient had a complete response. We've also seen responses in Hodgkin lymphoma using CD30-directed CAR T cells. This patient had bulky axillary lymphadenopathy, completely gone after a single infusion. And while it's been more challenging with solid tumors, we have seen some success. Glioblastoma is one of the cancers with the poorest prognosis in children and in adults. And after a single infusion, this patient had massive shrinkage. And we've also seen complete responses here on these slides with patients with neuroblastoma and rhabdomyosarcoma as well. So I'll pose the question to you. Are we there yet? Are we able to cure cancer with CAR T cells? Not quite yet, but the road has certainly been paved. Thank you so much for your attention. Here's some helpful changes and also references. Thank you, guys.